Hello everyone. Now today we will be discussing about our next topic of nephrotic syndrome. Previously we have discussed about the nephritic syndrome. Now we will talk about nephrotic syndrome. Okay. The nephrotic syndrome the hallmark of this disease is proteinuria, and the proteinuria that is in nephrotic range, and the nephrotic range proteinuria is known as the loss of protein in the urine greater than 3.5 gram per day. Okay, so this proteinuria, there will be hypoalbuminemia. Since there will be hypoalbuminemia due to the loss of the protein, there will be decrease in oncotic pressure of your blood vessels. If you remember, we have talked about the filtration pressure in the glomerulus also. There are the four forces that apply on it. One is hydrostatic pressure and one is the oncotic pressure. Hydrostatic pressure try to push the fluid out of the capillaries, whereas oncotic pressure try to hold the fluid, try to suck down the fluid. That is the important. Okay, so if the sucking down fluid, the oncotic pressure goes down, then also the pressure differences increases and edema occurs. Okay, so due to decrease in oncotic pressure, there will be leakage of fluid from the capillaries and will develop edema. So this edema will be generalized in nature and mainly present as a dependent edema as well. Okay, so this edema has occurred due to hypoalbuminemia, which has occurred due to the loss of protein in the urine, and that was the hallmark of your nephrotic syndrome. And this has occurred due to the podocyte damage resulting in the disruption of the filtration barrier. You know, the filtration barrier was made of your endothelium, basement membrane, and epithelium. There is four size barrier as well as charge barrier. Look, albumin are size. The size of albumin is around 700 Dalton. That is enough to pass through this pore. But due to the charge barrier, this was repelled and was maintained in the blood. Now here in this nephrotic syndrome, there will be disruption on the barriers, and there will be disruption in the charge barrier as well as in the pore barrier also. The main damage is in the charge barrier, and since the pore is enough to pass normal in our kidney, also the pore is enough to pass the albumin. It is just the charge barrier that was repelling and keeping into the blood. Now due to the disruption of the charge barrier, that is due to damage in the podocyte, this albumin has lost in your urine and will result in your hypoalbuminemia, that is decrease in oncotic pressure, and decrease in oncotic pressure has reached to the edema. Okay, so before understanding edema, how this occurs, let me give you a small overview of edema. That is not the part of this, but let's rapidly revise it. Normally this is your capillary end. There will be the capillary end and the venous end. Okay, in the capillary network, what happened at the end of your arterial, the water contained in the blood with nutrition, oxygen, that diffuse out into the tissue. Okay, what happened in the tissue, whichever tissue we are taking, in the tissue what happened, the fluid comes out from the capillary end and that goes to the tissue and give the oxygen supply, nutrition supply. Okay, wash out all the waste product and then suck back by the oncotic pressure. This is two things you need to remember. Okay, one is we are talking about the hydrostatic pressure increase in there is a hydrostatic pressure increase in capillary end. You know that cardiac output force is there, hydrostatic pressure is there, so which decreases down the venous end. Okay, so hydrostatic pressure is increased in this portion. Hydrostatic pressure is increased, so fluid has leak into the gums, comes to the tissue fluid, goes into tissue fluid, supplies the nutrition, oxygen, take back out all the waste product, and that has been sucked down by the oncotic pressure present in the vein. The protein in the vein that creates the negative oncotic pressure, and that sucks all the fluid that has been leaked out from the blood and again back into the blood. Initially it was come out with the oxygen and nutrition, now it is going back with the nitrogen waste product, and in this way your body is maintaining the blood volume inside the circulatory system. Okay, this is very important, you have to understand it. Okay, and while leaking out, there is a leak out of some small amount of protein as well, but that protein is usually drained by the lymphatics and again into the vein. So everything is maintained. Okay, fluid comes out in every portion. There are a lot in every portion of your tissue. They goes there. They supply the oxygen and nutrition, take back the nitrogenous oxygen and nitrogenous waste and other waste products, and come back into the vein. Comes to the heart, drain to the right heart, then it goes to the lung, get oxygenated, left heart. And this way the process is continuous. So in every part of your tissue, the fluid will come out from the capillaries, wash out everything, and then again go back into the vein. And the force that has leads to come out is hydrostatic pressure, and that has lead to sucking into the blood vessel is oncotic pressure. Now, since there is a decrease in oncotic pressure, so if there is decrease in oncotic pressure, the hydrostatic pressure by which the fluid will leak out and come into the tissue will be fine. But it has come with oxygen, come with the nutrition supplied to your tissue, but while going back into the vein, it's need oncotic pressure, and that oncotic pressure is measured was determined by this albumin content of your blood. And if there is albumin, is hypoalbuminemia, so there will be decrease in oncotic pressure, and since oncotic pressure is decreased, now the fluid will not able to suck out into the vein, and the fluid will accumulate in your tissue fluid, and this is how the edema occurs. One more point, if you go further, then this edema will be pitting. Why? Because this lymphatic drain is fine. This protein content is actually drained into the vein. There is no problem. Even some amount of fluid is also will be drained, but the amount of fluid that comes here is high, so the edema will more and more. Okay. Now another scenario, in another patient, you will find that the hydrostatic pressure is high. Okay, oncotic pressure is normal, fine, but the protein that has been leaked out into the tissue, that is usually drained by lymphatic. If the lymphatic is obstruction due to parasite, due to cancer, due to anything, then what happens? This protein gets accumulated, and in the long course of time, what happens? This protein is now able to hold the water. Although in your blood there is no damage in the protein, there is no hypoproteinemia, but also the protein that is present in the tissue can have a property. It is also now exerting oncotic pressure outside. So that will hold the water and develop the edema, and this type of edema is known as the non-pitting edema. So you should be clear about pitting and non-pitting edema. Actually, I was talking about edema, which is not a topic of nephrotic syndrome, but you need to understand it here very clearly. We are talking about edema, and that is edema is due pitting edema. Okay, nephrotic syndrome. Since we are talking about the edema mechanism, then let's be clear of non-pitting edema as well. And that will be very, if you are understanding, this is very easy to understand the edema, and it is very important actually. Okay, even I am feeling very good after explaining this to you. Okay, now coming to the edema, since there is a generalized edema in the body, then there will be the other factor that will even precipitate the edema. And what are the factors? Since edema is there, now fluid has leaked out from your blood vessel, there is low volume in the blood, so blood is concentrated, so there is hemoconcentration. Since there is hemoconcentration, there will be increase in osmolarity, and since osmolarity will increase, it will goes to the hypothalamus, then increased osmolarity will be cause the release of ADS from the posterior pituitary. This ADS will rush back to the kidney in the distal convoluted late part of the kidney, and they try to absorb the water, and since they absorb the water, now water and sodium will be retained, and that again will leak out into the outside of the fluid and cause further aggravation of edema. Okay, so these are again contributing factor of edema, and edema is more increased. Even if there is less volume in the blood, then there is a low volume in the blood. Low volume in the blood will increase in the activation of the renin-angiotensin-aldosterone mechanism. If renin-angiotensin-aldosterone mechanism is activated, then aldosterone will release. Aldosterone, you know, that has the capacity to absorb the water and sodium and water, and it release the potassium. Since sodium and water will be absorbed, this will again leak out from the capillaries and will further precipitate the edema. Okay, now there is another mechanism: less volume blood, low volume in the blood, less water in the blood, low volume in the blood. RAS is activated. RAS is activated. There is the release of angiotensin 2. You know that. That is a vasoconstrictor. Vasoconstrictor will increase hydrostatic pressure. This force will be more increased. And since this force is more increased, more water will come in the tissue fluid. But taking the negative suction, oncotic pressure is less. Now since oncotic pressure is less, what is not going but more water is coming, so it is again aggravating your edema. So the characteristics of your nephrotic syndrome is Hallmark was proteinuria, that is loss of protein index greater than 3.5 gram per day, and that has leads to hypoalbuminemia, decrease on cardiac pressure, edema. Edema contributed to the other factor. So what are the characteristics? You will have proteinuria greater than 3.5 gram per day, hypoalbuminemia, edema. Yeah, and you have understood this thing. Okay. The other characteristic, other presentation, other clinical features of nephrotic syndrome includes, since there is a loss of proteinuria, you have understood the condition. Now you have to also understood that since there is a loss of protein in the urine, the liver is the storehouse of your protein. Then it will secrete the protein into the blood. Okay, it will secrete the protein into the blood, and the range total is 10 to 12 gram per day. Actually, you will say, sir, there is loss of only 3.5 gram from urine, and liver is supplying 10 to 12 gram. Then what is that? Why we are having hyperproteinemia? Actually, all the protein is actually there is the proximal convoluted cell, and proximal convoluted cell eat up all this protein. Okay, so all the protein that has been produced, now this is leaking into your tubule. Okay, this protein one. Then that is this proteinuria we are talking about is found in the urine, but lot of protein has been get penocyte and damaged by this cell present in the proximal convoluted. So other protein around, say, what you can say, even 8 to 10 gram is damaged by your PCT. Because of that, you are having, even there is a compensation of 10 to 12 gram per day, but all protein has been damaged and some are lost in the urine. So there is having hypoalbuminemia in the blood. Okay. Then there is a loss of, since during the compensation, the liver also produces lipoprotein. It produces protein, but it is not selective to produce only protein. It also releases out the lipoprotein. And since lipid component is increased in the blood, then there will be hyperlipidemia and hypercholesterol. In hyperlipidemia, actually we can say that this lipidemia, because LDL, as there will be increase in LDL, VLDL, high LDL, but decrease in SDL. Okay, so increase in LDL, VLDL, IDL, but decrease in SDL. So this is decreased, but other are increased. So this can be said as dyslipidemia. But you have to say that there will be increase in triglycerides as well. So hyperlipidemia you can say, or dyslipidemia, and there will be hypercholesterolemia. That you have to understand. Okay, so we are having proteinuria, hyperlipidemia, edema. Okay, hyperlipidemia, hypercholesterolemia. That you have understood. Since there is hyperlipidemia and hypercholesterolemia, the lipid content will be lost. And again, when losing this proximal convoluted cell will again take the lipid also and damage and eat it, and even this cell will be get loaded by lipids. Even some lipids are lost in the urine, and thus protein content and the lipid content high in the urine has leads to the frothy urine. So there is frothy urine characteristics you will find. Okay, now since there are losing everything, lot of losses are occurred. Even there will be loss of antithrombin 3. Antithrombin 3 is the thrombin cutter. Since they prevent us from thrombosis in our body. Now if it is a decrease in the body, now there will be a chance of thrombosis in our body, and there will be hypercoagulable state, and there will be a chance of thrombosis. Even renal venous thrombosis occur. There will be thromboembolism condition in the nephrotic syndrome. Okay. Now there will be loss in the urine. There will be loss of complement animal globin as well. Since complement animal globin is lost, there decrease in complement and hemoglobin will increase chance of infection. So in a nutshell, if you want to summarize it, then what we are talking about: nephrotic syndrome, hallmark proteinuria due to damage of the podocyte, due to disruption of the Charles barrier, that is the filtration barrier. Hallmark was proteinuria. Proteinuria has leads to hypoalbuminemia, that is edema. So what are characteristics? Proteinuria, hypoalbuminemia, then edema. Edema, other factors are there. Okay. So one is proteinuria, hypoalbuminemia 2.3 is edema. You have to remember this generalized edema. 4th is frothy urine presentation. 5 is thrombosis. There will be 6 is hyperlipidemia and hypercholesterolemia, and 7 is increased chance of infection. So if a patient presents with this 7 feature, or most of the about 3 or 4 or 5 features of among these 7, then you have to clinically, this is the clinical feature of your nephrotic syndrome, and you have to identify that okay, the nephrotic syndrome, this patient has nephrotic syndrome, and we have to look, this is the clinical feature, because this 7 presentation will be the clinical presentation due to nephrotic syndrome, but we still don't know why nephrotic syndrome has developed, which part of nephron, what was the damage, what was the cause, we still don't know. So we need to know that cause as well. And for that, there are the 6 or 7 causes like minimal change disease, focal segmental glomerulosclerosis, amyloidosis, diabetic nephropathy, membranous nephropathy, and 2 we have already discussed, that is DPGN and MPGN, that is diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. We will discuss the cause, why it has been occurred, what was the damage in the glomerulus that has led to this clinical facies, lead to develop a nephrotic syndrome, and lead to development of this clinical facies will be discussed in next lecture.